Well, good morning, everybody. I'm Eric Linzer, President and CEO of the New York Health Plan Association. Welcome to day 2 of our annual conference, Decision 2020, What It Means for the Future of Healthcare. We're excited to have everybody back with us today, and we've got a great set of conversations that'll be coming up throughout the course of today's conference. In case you didn't catch yesterday's session, we had a great conversation with Don Levy from the Siena College Research Institute, who provided us with his update and overview of the recent 2020 elections, what they meant for New York and their implications for the healthcare system. In addition to that, we had a great panel discussion featuring Sabrina Corletti, Luis Cohen, and Dr. Aditi Gupta, talking about the impact that COVID-19 has had on the healthcare system and their implications for the future impact of healthcare going forward. If you weren't able to join us yesterday, all the sessions have been recorded and video links are up on the virtual site, both online and in the mobile app. So we've got a great couple of several panels set up for us for today. We're going to kick off in just a little bit with a panel discussion addressing the opioid crisis. Our friends from Shatterproof will be joining us to talk about an overview of the current challenges related to bridging the gap between evidence-based medicine, policy, and practice, and provide an update for us on their activities here in New York and around the country. Following Courtney's presentation, we're going to be joined by several local prominent leaders to talk about the issues that Courtney will raise. Next, we'll look at states' efforts to curb prescription drug costs. Joel Menges will provide an overview of the growth in prescription drug spending and approaches that states are taking to contain those costs, including a discussion of the shortcomings of carving the pharmacy benefit out of managed Medicaid. A panel of national and local experts will join Joel as part of that conversation. And then our final panel of the day will be on maintaining momentum on payment reform in the midst of a pandemic. Andrea Caballero from Catalyst for Payment Reform will be back with us again this year to provide an update on how the move to value-based payment arrangements are proceeding and what challenges they're facing in the midst of the current pandemic. A panel discussion will follow Andrea's presentation. In addition, at 11:15, Pondera Solutions will have a virtual coffee break, so we hope to see you there. Now, before we get started, I wanted to once again thank our sponsors for helping us make this year's annual conference possible. In particular, I wanted to thank our diamond level sponsor, Pondera Health Solutions, as well as our platinum level sponsors, Liberty Dental, Envolve, and Omada Health. I also want to thank our exhibitors and encourage you all to take some time today and tomorrow to check out them as part of our virtual exhibitor conference space. Simply click on the link either on the left-hand side of your screen or in the mobile app on the exhibitor booths to visit our 18 exhibitors. As an incentive, and I talked about this a little bit yesterday, we've got a great gaming challenge. As you go through the exhibitors and look at their descriptions, we've embedded in a 4-digit code as part of our gaming challenge. And if you haven't already looked, we've got a tight race atop the leaderboard. So if you haven't checked out the exhibitors yet or haven't gotten involved in the gaming challenge, there's still time. As a reminder, we're going to be offering some great prizes to our top 3 point earners. First prize will receive a $250 Amex gift card. Second place will receive a $100 Amex gift card. And third will receive a $50 Amex gift card. And as a reminder, given the tight competition on the leaderboard, in the event of a tie, we will be holding a drawing Thursday afternoon at the end of the conference. So with that, I'm now going to mask up and then turn the controls over to HPA's Executive Vice President, Kathy Preston, who will introduce and moderate the discussion for today's first panel addressing the opioid crisis.
Okay, we stayed socially distanced the whole time with wearing masks. All right, everybody. Good morning. I'm Kathy Preston from HPA. It's my pleasure to introduce our next panel and to moderate the discussion that will look at efforts to bridge the gap between evidence-based medicine policy and practice. We are going to start the session with a presentation from Courtney Hunter, the Vice President of State Policy at Shatterproof. In this role, Courtney is responsible for engaging state policymakers to eliminate barriers to addiction treatment, access, and increase training and education of healthcare professionals. Prior to joining Shatterproof, Courtney spent 11 years at the Partnership for Drug-Free Kids. During her time there, she worked in media relations, program management, and government affairs. Courtney was responsible for developing the partnership's advocacy program and instrumental in the introduction of bicameral and bipartisan Family Support Services for Addiction Act in early 2020. Joining Courtney is Senator Peter Harcum. Senator Harcum was first elected to represent New York State's 40th Senate District in November 2018. He is the chair of the New York State Senate Committee on Alcoholism and Substance Abuse and the founding co-chair of the Senate Task Force on Opioids, Addiction, and Overdose Prevention. One of the biggest investments of Harcum's time and effort during this first term was the Opioid Task Force. Also with us today is Kelly Hansen, Executive Director of the New York State Conference of Mental Hygiene Directors. Kelly has over 30 years of experience in New York State government and public policy. Prior to joining the conference, she held positions in both the State Assembly and State Senate, the Governor's Council's office under Governor George Pataki, the State Department of Health and the Office of Governmental Affairs, and later as Director of the Adult Home Quality Initiative. I have worked with Kelly for that whole 30 years, so it's been great. She's a member of the New York Community Advisory Board, CAB, of the Healing Communities Study, and was appointed to the as New York's CAB representative to the National Steering Committee for the study. The Healing Communities Study is a federal research study collaborative effort of the NIH and SAMHSA, launched to investigate how tools for preventing and treating opioid misuse and opioid use disorder are most effective at the local level. And finally, Dr. Angelia Smith-Wilson, Executive Director of Friends of Recovery New York. Dr. Smith-Wilson brings over 20 years of human service and addiction experience to Friends of Recovery New York. Her career spans across working with human services agencies that have served individuals with mental health, substance use, residential and homeless issues. She has worked as an intensive case manager, a primary therapist, a director of client services, eventually progressing to the level of vice president throughout the greater Rochester area. Angelia has centered her career around improving treatment outcomes for those in recovery, as well as exploring research designed at substance use counselor development. She continues to study cultural responsiveness and deliver trainings in the area of race and recovery and other cultural humility trainings. Welcome to all the panelists, and thank you for being with us today. Now I'm going to turn the session over to Courtney, and so we can get started with our discussion. And following Courtney's discussion, I will moderate some questions, and attendee questions will be available in the Q&A section at the bottom of your screen, so feel free to add questions. And with that, I'm going to turn it over to Courtney. Thank you.
Thank you so much, Kathy, and thank you to the New York Health Plan Association for having Shatterproof here, and for my fellow panelists. So nice to be with this distinguished group of folks. Senator Harcum, also thank you for your removal of prior authorization on buprenorphine earlier this year. That made a huge difference in the state, and we're so grateful. So I'm going to go through a few slides right now and share my screen. I did it. Okay. So thank you again. I'm here to discuss addressing the opioid crisis. My name is Courtney Hunter, and I'm the Vice President of State Policy for Shatterproof. For those of you who don't know, Shatterproof is a national nonprofit founded in 2012, dedicated to reversing the addiction crisis in the US. And we're very focused on ending the stigma of addiction, and also ensuring that treatment in the US is based upon proven research. And we're doing that in a number of ways by trying to close this treatment gap and improve addiction treatment access and quality through alignment with national principles of care for specialty treatment and addiction. And I'm going to talk about our Atlas initiative in a little bit. Through removal of regulatory barriers and also increased provider education on addiction, And then finally, is something I'm very focused on is integration of primary and behavioral health care services, particularly within Medicaid across the country. And so before we get into kind of the meat, I just want to level set and talk about the scope of the problem right now in November 2020. And not to be depressing, but to sound the alarm really for what it is that we're seeing now in terms of increased overdose rates and lack of access to effective evidence-based treatment continues to be a dire problem throughout the country. And we do know that in times of economic recession and unemployment are correlated with increases in prevalence of substance use and addiction. And we have seen some troubling suspected drug overdose numbers rising nationally. And so we really need all the tools in the toolbox, everyone to come together to have a comprehensive solution. We have seen from Wellbeing Trust some projections over deaths of despair. And in a recent survey, 79% of all registered voters say that the situation with COVID has affected their mental health, including 39% who say it has affected it a lot. So this is a significant problem. We're also seeing that suspected drug overdoses are increasing because of the combination of fentanyl within the stimulant supply. So there's that issue as well, which is contributing to the rise in overdose deaths. That's more anecdotal at this point. We don't have substantial evidence, but that's what we've been, kind of hearing, if you will. And finally, and I know Angelia will talk about this a little bit, but the disruptions in treatment plans, and we've had to change the whole way that we look at treatment now through COVID and those in recovery, increasing the risk of relapse because of disruption in treatment, because of social isolation. So this is the current landscape. And with that, I think it's all of our duty to really sound the alarm and to continue to look at innovative solutions, evidence-based solutions, and to work together. And so with that, in terms of closing the treatment gap, this was the situation before COVID, was that 1 in 10 people who needed addiction treatment will ever receive it. Even fewer will receive treatment based on proven research. So this is abysmal. Why are we not meeting the needs of 90% of this population? And this is just my conjecture, but I think it's regulatory barriers, a mix of regulatory barriers, limited supply of providers and evidence-based programs. We're currently treating addiction at stage 4 in the disease state. So we're treating it in emergency rooms after an overdose. We're not treating it in, stage 1 in the earlier stages. And stigma continues to be a major issue, pervasive issue among providers who are treating people who use substances, and also self-stigma, the shame and the isolation, and the stigma of seeking help. And so at Shatterproof, we've really set out through, we worked with the author of the Surgeon General's report a couple of years ago to really set some measures around what are the quality expectations for addiction treatment, because what we hear from payers is, well, there's all this predatory practices, or we don't know what good treatment looks like. Is it 30 days inpatient? What are the levels of care? There's just a lot of confusion. And so we set out to say, like any other chronic illness, here are the principles of care, and working with the American Society of Addiction Medicine on that as well. And those include things like personal plan, so individualized care, coordinated care, medication, just like you would have for any other illness, and also ancillary supports like recovery supports and family supports. We know that outcomes are better for people when they have recovery supports and family supports and family therapy than if they don't have that. And so our program, which is called Atlas, which is actually in New York, is one of the states where it is. And we've worked with a number of the payers and the providers in the state and other organizations. And Atlas stands for Addiction Treatment Locator Assessment and Standards Platform. And so it's a couple of things. From a consumer standpoint, it helps families navigate the treatment process based on level of care and based on these national principles of care. So we're utilizing patient feedback, provider information and data, and also Medicaid data and claims to level up treatment facilities against those national principles of care. So you're not just going from a consumer perspective to Google and entering in rehab near me, detox near me, and just getting bombarded with a bunch of information or a fancy web page and not understanding, not having your hand held through the process. There's a lot of fraudulent information out there. There's a lot of good information, but it's hard to ascertain, is particularly in a moment of crisis, what you or a loved one needs. And that's one of the problems that Atlas is helping to solve in the state. And this was created by a $5 million project from philanthropy, funded in 6 states. You'll see New York is one of them. And as I mentioned, we've been forming these state advisory committees. And so everyone has really come to the table. There's no pay to play. We don't take money from providers. We didn't want any, perception of not being, fair and equitable in our analysis. And so in that, we've really brought the payers, the providers, the recovery groups, and everyone to the table. And we think that is to help inform really what quality looks like, and to help people at the state level find evidence-based care. And this is what I mentioned, that we have a few different users coming together. We also have provider portals just for the providers. So there's unique information on that side as well. And a couple of the data sources that I mentioned. So the commercial and Medicaid claims, treatment facility reporting, and then also patient and family member reporting, which we feel like is really important. People really rely on that kind of information, especially in today's, environment of reviews. And, asking, you would ask, just like you would ask your neighbor, where did you go for cancer treatment? And you would trust their opinion. We're trying to fight stigma in that same way and bring addiction into the medical mainstream by including patients and family members in that process as well. And so with that, the other thing I mentioned at the top of this, in terms of closing the treatment gap at the top of this presentation, is eliminating policy barriers and expanding education for addiction treatment. And so on the federal side, we're really focused and supportive of 2 main efforts. One is the Medication Access and Training Expansion Act, MATE, which just got a Senate companion earlier this fall. And this would allow all medical schools and residency programs to fulfill a certain amount of hours of training on addiction. And this is very exciting for us to see that our future practitioners would be able to receive a base level training of addiction, and also helps with bringing addiction into the medical mainstream, talking about addiction like it is any other disease, and talking about the treatment options so that our future practitioners know how to treat and how to prevent the disease as well. And then the second is the Mainstreaming Addiction Treatment Act, and this would eliminate the separate waiver at the DEA level to prescribe buprenorphine for addiction treatment. We know that about 4 to 5% of all providers have actually received the waiver. And so only about 5% of providers, and that includes physicians, physician's assistants, and nurse practitioners, are even able to prescribe medication for opioid use disorder. And buprenorphine is one of the most effective treatments that we have for OUD. So we really need to expand access. And while this waiver was created with good intent, it is now really impeding access to care. And even half of the physicians who are waived are actually prescribing buprenorphine. So that's about 2.5 to 3% of providers are actually prescribing buprenorphine. So I cannot stress enough, the outrage that we need to have of getting rid of this requirement and allowing for increased access to buprenorphine. And that's at the federal level. At the state level, there's a number of things that states can do to improve treatment access. And at Shatterproof, we're really working with states to utilize these levers. One is to cover medication-assisted treatment to remove pre-authorization requirements. So I mentioned New York just did that this year. Thank you to Senator Harcum for sponsoring that bill. States can also really maximize their Medicaid behavioral health waivers, the 1115s. We've seen this in a number of states that have expanded treatment recovery services and other supports. Really important in COVID times, we can allow for telehealth reimbursement of behavioral health services and also induction of medications for addiction treatment over telehealth. And that has been allowed in some states through COVID, but these are not permanent. These are really temporary. So we need to look at those and evaluate. As I mentioned before, we can really align our payment policies with these national principles of care for addiction treatment. What is the evidence saying? How can we support these evidence-based practices with reimbursement and payment? We also, we'll talk about this a little bit more, we can incentivize integration of health services from primary care and behavioral health care through partnerships and also state Medicaid managed care contracts or a state planning amendment. And New York is doing this a little bit through the collaborative care model, and I'll talk about that in a bit. And then another, huge issue here in terms of closing the treatment gap is capacity. We need more health professionals that are trained to provide addiction care and ones that feel supported to provide addiction care. I can't tell you how many primary care providers I talk to who say, I don't even want to screen for SUD because I don't know where to send people. I don't have the support. I don't know how to handle this. And that's not their fault. We need to support them in that process. And so we really need to train all healthcare professionals on addiction care and also medication for addiction treatment. We should be utilizing telehealth models as well to have continuity of care and enable care delivery. We've seen that with the explosion of telehealth that it's also correlated with stigma reduction. And there's been, just an increase of, a decrease in the no-show rates because it's just more convenient for people than, taking an hour out of a lunch break and going to the doctor's office every day, for example. So all of those things can really help increase the treatment capacity and integrate services. And so at Shatterproof, one of the models that we've really looked at from an alternative payment standpoint that we feel like is just such a wonderful bridge to full integration is the collaborative care model. And it's really an integrative treatment approach that relies on the primary care provider as the main billing practitioner with a care management staff and also a psychiatric consultant or a specialty addiction provider. And we feel like this is so critical to socialize with people and to let them know, because a lot of providers and also payers don't know that It doesn't have to be a psychiatric consultant. It can be a specialty addiction provider. And CMS has been very clear on their guidance in 2018 when they issued codes that it can be utilized to treat SUD as well. And so there's about 15 states that are currently covering collaborative care within Medicaid. And New York is one of them, but New York is only covering it for certain disorders and diagnostic codes. And so we'd like to work with them to expand that and see how we can also be treating SUD or work with MAT providers and OTP providers to expand access. Something that's also very exciting about this model is it relies on measurement-based care. So we're tracking patient progress, we're understanding what's working, we're learning a lot, and we know that there's a sense of quality and evidence behind the model. It's been actually shown in more than 80 randomized clinical trials to control health, to improve health outcomes. And there's been some recent research around opioid use disorder and also alcohol use disorder, and how this model has really improved treatment outcomes. And I have some of the numbers there, but it's very well documented. We just released a white paper on this front. And in terms of the opportunity, why we were so excited about this and working with states to really close the treatment gap is that 80% of patients who are receiving behavioral health care or seeking to receive behavioral health care are doing so from their primary care practice. But those primary care practices are not supported clinically to provide these services to their patients. If they are doing so in a non-collaborative care setting, they're giving a referral that may or may not be followed up on. And so we feel like this is such a huge opportunity to really start treating addiction more upstream and less in emergency rooms. We also know that 50% of individuals with a mental health disorder have a comorbid substance use disorder. So this is something that, this is a payment model that really integrates both of those diagnoses in a way that is effective. There's also a health equity aspect here. It's one of very few interventions that has shown to reduce disparities by race and ethnicity and socioeconomic status in terms of the quality of care and access to care. And there's also a cost savings associated with just reduction in overall spending, ER visits, better physical health, and those sorts of things. And so I know I shared a lot and covered a lot of different issues, so thank you for bearing with me. I really cannot stress enough that how important it is for all of us to work together to address this urgent need and to bring addiction into the medical mainstream. We all have a role to play here, and some of the things that I outlined today are ways that we can work together to improve treatment access, to improve quality, and to integrate services to help improve outcomes for those struggling with substance use disorder. And I look forward to continuing the conversation and working with you all. And with that, I'll hand it back over to Kathy.
Okay, Courtney, thank you very much. As you said, that was a lot of information, so we have a lot to talk about. Before we kick off our panel discussion, I just want to remind our attendees that if you wish to submit a question, enter it in the Q&A section at the bottom of your screen. Okay, we'll try to get to as many as those questions as we can with the time we have. Okay, we'll jump right in here. For each of our panelists, what's your reaction to the issues Courtney has outlined? Angelia, I'd like to start with you, if that's okay.
Thank you. And thank you to the New York Health Plan Association for inviting me to be a part of this panel. Courtney, lots of information, great information. You know, for New York has been forever admiring Shatterproof an atlas from the beginning. And when I kind of entered at For New York, immediately started to reach out to Shatterproof to get more information about it, because the instrument atlas is, it is so needed. It is so needed because, as Courtney mentioned, members of our community are reaching out at really dark times in their lives. And so the information that they receive, it is critical that it be appropriate, that it be culturally responsive, that it be accessible. And so any way that we have of making sure that the information that is out there is appropriate, is accessible, is culturally responsive, is all of these things, is critical. It is critical. So my reaction is that, we are in full support of Shatterproof. We are in full support of any approach that uses qualitative data from the participants, the people, right, captures their voice as one of the primary drivers and improving our overall addiction and behavioral health system. So our reaction is we will continue to do whatever it is that we can to support Atlas and Shatterproof in making sure that individuals receive or have access to treatment that is going to save lives.
Thank you. Senator?
Good morning. Thank you, Kathy. Thanks to the Health Plan Association for the conference, and it's great to be with all my colleagues on this panel, folks who are real leaders who have done so much to move the needle. So it's great to be with you all. And Courtney, thank you for a great presentation. There, as Angela said, there's just so much there to comment on. Number one, thank you for sounding the alarm, because we had a crisis before we had a pandemic, and you're absolutely right. The pandemic has made it worse. You're talking about deaths of despair. We have seen that evidence. We've heard from providers the challenges that they face in terms of dealing with this, increased demand with less capacity. People could put 2 or 3 in a room in an inpatient setting. They're now down to 1. If they were having group therapy, they can do it by Zoom, not necessarily the same thing. Telehealth, I think you really hit the nail on the head in terms of the efficacy of getting people at a higher rate of compliance. We've heard that from providers because it's easier. We're working on legislation getting Medicaid to reimburse peers, which are now so valuable to helping people in recovery. You talk about doctors on the federal level with your legislation, understanding addiction when they're prescribing. We have legislation that we're working on. We passed it once in the Senate, not in the Assembly, but we're refining it, that would require doctors and dentists who provide opioids to their patients to have a conversation about the risks and what the alternatives are. Because you're so right, we've got to get people at stage 1, not at stage 4 when they're so vulnerable. Some of the concerns I have, is that this is an underfunded sector of the healthcare society. It's always been, both at the federal and the state level, and now the state has 20% cuts in reimbursements. We have seen providers close because of this, and how is it impacting care? We talk about quality and access to care. Obviously, it's going to reduce both. And so how does that show up in the quantitative data? This absence of adequate funding. And finally, I really like what you said about the co-occurring disorders, because that is really a big chunk of the problem. And unfortunately, we still have these funding silos in many cases coming down from the federal and the state level. So, I certainly accept your call to work collaboratively, with government and providers and patient organizations and our municipal partners. This is a great group we have here today, and look forward to the conversation. Thank you.
Thank you. Kelly. And I think you're on mute, Kel. There you go.
All right. Thank you. Thank you so much again for the invitation. Senator Harcum, it's nice to see you virtually. And on behalf of the County Mental Health Commissioners, thank you so much for your support, your advocacy, your great staff. We appreciate all of that. So I want to kind of pick up on, thanks for the segue, on the co-occurring disorder piece in terms of Courtney's discussion about the treatment gap. And the collaborative care model is good, and I'm so glad that Shatterproof is working on that for the SUD space. And I think Path Forward has done some work on private commercial insurance and access that way. So to bring those two together, I think is great. OMH did a collaborative care model in 2015-16, I think, before the substance use piece was out there in terms of moving mental health services, not so much services screening. So it's a PHQ-9 for depression and a generalized anxiety disorder screen for anxiety and depression. That's the most common, very often treated in a primary care setting. And they implemented that over years. And so what they found is, you know, it did work well, but there's a couple factors. You know, I'm a policy person, so there's a couple factors that need to put this in place. And you need a really high volume. You need a really good electronic health record that captures the screening, and that the biggest time piece that they had was billing. So those are all factors that ultimately turn into barriers. But I'm very, you know, as representing the county mental health commissioners, our county commissioners are already integrated locally. So they are responsible for mental health services, OASIS services, and developmental disability services. So locally, we're already integrated. We've been doing this for 40 years, and the counties work extremely closely with social services, with housing, with shelters, with the criminal justice system, with the court system. It's all integrated locally, and they, when we get to this discussion about co-occurring disorders, I can't stress enough how much it is necessary to really look at the whole person. You know, Courtney, you had a statistic that 50% of individuals with a mental health disorder have a co-occurring substance use disorder. If you flip that around, 70% of individuals with that are addicted to substances also have a mental health disorder. So the link between the two is just so, these numbers are like undeniable. And so we need to be able to treat the person as opposed to treating the illness. And the fragmentation that is happening now, which, you know, hopefully over time will be more integrated, is something that really needs to go forward. And I think there's been some wave you know, with research in the last couple of years in terms of recognizing the impact of trauma, real trauma on childhood trauma through ACEs scores, recognizing that impact and being able to look to the future and see that there's a mental health issue, there's substance use disorder. So being able to see that trajectory in terms of not treating at stage 4, but treating at stage 1 and screening and really, you know, getting those pieces accessed in advance. So.
Okay. So next question, I'm going to combine a couple questions here. So a lot of Courtney's presentation talks about the importance of measuring outcomes and the value of measuring those outcomes. So I'd like to hear from our panelists of how do you incorporate outcome measurement and the value of outcome measurement in how you approach your work, whether it's policy or drafting legislation or providing services. So Kel, I think I'll start with you.
Okay. We'll keep going. So, you know, I think, and outcomes isn't always my strong suit, but I find that I question them a lot, and I wonder what specific, you know, what's a good outcome for the people we care about? What's a good outcome for behavioral health? And how do you measure that? Now, National Quality Forum has been doing a tremendous amount of behavioral health outcome measures. So, you know, the 7 and 30-day readmission. Were you prescribed a, you know, medication as necessary? And so in the last few years, we've seen a big, leap toward really getting some standardized national outcomes, and I think that's really encouraging. But I think there's a lot of other outcomes that look at the whole person that are difficult to quantify. So, and I'll just use an example. So if someone is being treated for alcoholism, and when they start being treated, they're drinking 7 days a week. And then, over time, they're getting treatment, they're staying in treatment, they're doing well, they're working with a peer, and now they're drinking 4 days a week. That's a good outcome. Is it abstinence? No, but are we going in the right direction? And to really be able to do that time overview for outcomes. So I think it's complex, and I think you need to incorporate more than did this process happen or did this treatment happen. But again, look at the whole person. It's behavioral health.
Great. Thank you. Angelia, would you like to build on that?
Yes, I agree with what Kelly said with regards to looking at the whole person. And certainly, how do you mitigate for racial disparities? How do you mitigate for stigma within outcomes, right? And so I think that that's one of the biggest issues that we have when we fail to do that. And how do we do that? It's going to take national standards that have taken the time to consider that and that have done research around that, because you cannot realistically look at how whole a person is when you have not considered those factors and in terms of outcomes. So, some of the things that we look at in the recovery community are, having the person be able to define what is a meaningful life to them, taking into consideration the things that I've said, their community, their culture, even how they respond to treatment, even having the ability to match, have treatment match with regards to therapist match or whatever the case may be. So I think that, outcome measurement is important in terms of really being able to evaluate the efficacy of anything. But when we work with people, it can get complicated, right? So it needs to be three-dimensional as we are. And it needs to be able to mitigate for those environmental variables such as stigma, which is a huge one, which takes itself and roots itself even into policy formation. And so we have to be considerate of these things and how do we mitigate for that when we design outcome measurement approaches.
Okay, thank you. Senator, having heard Kelly and Angelia, would you like to add anything here?
Sure. Thanks to Angelia and Kelly. That certainly said a lot, and I agree with everything they've said. Some outcomes are more obvious, like with Matt and the research behind that, which was why we all work so hard to end prior authorization. But I guess two of the areas is we just understand that relapse is part of this disease. In my own case, it took me several tries before I was able to get sober and drug-free. And we see that across the spectrum with a lot of folks. So we need to be careful on how we incorporate that element of the disease into the data and into our outcomes. And the other is a piece that I mentioned before. Are we adequately funding the organizations to get the outcomes that we desire? So if an organization is not getting the outcome we desire, is it because they're not using the right protocols, or they're not adequately funded to meet all of the criteria for successful outcomes?
Okay, great, thank you.
Okay. Just add to that.
Yes.
I just want to also add, this is such a wonderful discussion. I'm so excited to work with all of you after this. And it really, outcomes also really hinges on level of care and understanding the appropriateness of care. Treatment doesn't equal 30-day inpatient. It might for some people, but maybe keeping your job, keeping your kid at home, and having medication and intensive outpatient is a better outcome, and will help you keep the stability in your life and moving forward. So I really also want to help socialize this idea of level of care. And, I think we have a really tough obstacle ahead of us because of like mainstream media and all of these other advertisements around luxury facilities and 30-day inpatient. And we have to knock down that idea that, and to bring addiction into the medical mainstream and to treat the opioid crisis, we have to embrace other levels of care and help consumers understand, what that means.
Great comment. Thank you.
Thank you.
And I want to keep bringing you back into the conversation here. We've talked a lot about the collaborative care model. So I'd like to focus on integration of primary behavioral health care. Kelly, Angelia, the Senator, you've all mentioned treating the whole person here, which is essentially what the collaborative care model is doing. Courtney, I'll start with you. Do you see barriers to getting to that place, right? Are there issues with taking that kind of a model to scale? Are there regulatory issues in New York that we need to address? And then one of the questions that came through that fits in with this conversation, I'm throwing a lot out at you here, Courtney, sorry,
No worries.
is how does the collaborative care model provide financial incentives to providers, right? To keep that access and make sure that they can do what they need to be able to do.
Okay, yeah, so there's a lot to unpack.
Yep, lots to unpack there. Yeah.
So in New York State in particular, the collaborative care model is covered within Medicaid, but for certain diagnostic criteria, so for depressive and anxiety disorders, and not for SUD. And they're looking at that, at expanding that. Part of the issue in New York State is New York State was so forward thinking and sort of developed this this model and worked with the AIMS Center at University of Washington to roll it out before CMS had official guidance in 2017, 2018. And at that time, they issued CPT codes for reimbursement. So to get to the financial incentives piece, yes, what I've heard from providers is that it's cost effective, that it's competitive. I wouldn't say you're going to make money by doing this, but I would say that it's cost effective. And from the payer standpoint, it's really cost savings in terms of the overall physical health and cost reduction. But as Kelly mentioned, the billing issue is one of the main barriers. And also just the ongoing measurement-based care. So there's a lot of it's a lot of burden on the providers to track everything, and there is also an uptake and an implementation period that has to happen with education and awareness and support for the primary care practices to do this. And they're the main billing entity. And then they would contract with the psychiatrist or addiction professional.
Okay.
So barriers, I would say, billing, support, implementation support. And if we want to expand this in New York State to address SUD, which I think would be a wonderful thing, and we could absolutely do it. I think working with OASIS and OMH to do that, and everyone on this panel would be wonderful, but we need, I think, some support in terms of implementation for the billing and also for provider uptake, training these physicians and providers on medications for addiction treatment, for example.
Okay, great. Other panelists have a reaction to that or anything they'd like to add?
No, other than to say, Courtney hit it right on the head. The billing is a real challenge for treating the whole person holistically when there are two sets of billings for one individual. And we know of cases where people will have to see different providers within the same treatment facility. They'll even have to, treatment providers have had to go so far as to have separate entrances. Those things are beginning to fade. But we still have big firewalls when it comes to the billing of treating co-occurring disorders.
Okay.
Kathy, if I could just add as well that, as part of the, billing, it relates back in part to the licensure. And so only recently, probably in the last, 8 years, has there been the ability for a clinic to get an integrated license. So, 34 of my counties operate a mental health clinic, and 14 of those also operate a substance use disorder clinic. And it took a long time to get those integrated licenses. The good news is they're there, and that's good. It doesn't correct the billing problem. But also just I just want to remind people that behavioral health didn't get like HEAL grants of multi-million dollars to do these sophisticated electronic health records and make sure that your health record can talk to the other 5 and that you're already in and be able to, get back information to the plan. And so, all of that comes together, and it needs, investment in this. And I always, defend our field here, because when you think of how much money went out multi-years, hundreds of millions of dollars to the, hospitals, all those systems, behavioral health didn't get that. So it's a barrier to us. But, there's some good things, I think, happening in integration, which I can touch on later, but I
go ahead.
to address that.
Go ahead and touch on it. Yep.
I'll touch on them. So,
Yep.
It just from the billing standpoint, not even billing, I'm sorry, more for information sharing. And Kathy, one of the questions you had asked us to consider was any federal barriers.
Mm-hmm.
But there's some good news out there. So there's a couple things that I think are helping this field. So number one, and you guys probably already know this, but under the CARES Act, there was a significant and really meaningful revision to 42 CFR Part 2 in terms of how you can share information and with consent, and it dated back initially to the 70s when everyone was discriminated against and your kids would be taken away and you'd lose your job, et cetera. And what that did is it aligned SUD information to the HIPAA compliance standards. So it brings things updated to, now we have systems that they didn't in the 70s. You've got ACOs and, qualified entities and things like that. So I think that's really going to help move us along. The other piece is with HIPAA, it really starts to recognize that this is a disease and should be treated such. It's not a criminal activity, it's a disease. And so I think once this 42 CFR Part 2 revision, which, is deep in the regulatory and legal piece, is ultimately going to have a real impact in terms of being able to share information and treat the whole person, even if you are in different settings. And then just finally, the federal state opioid response grants. These are the grants that were the second tier of opioid response grants. They widened the eligibility in that to be able to include programs and treatment for stimulants, so meth and cocaine, which Senator mentioned it, I think Courtney did as well. If you talk to anyone in law enforcement and others, you're seeing that this is our next wave. Mm-hmm. So giving the feds giving that flexibility and SAMHSA giving that flexibility, it allows us to, in programming, try to get ahead a little bit. So that's all.
Thank you.
And I just want to say, in regards to the integrative approach, we, one of the things that we kind of see is maybe like an invisible element of that is, recovery-oriented supports, the community-based support. As Kelly said, with regards to entities having to have the correct licensure, there are community-based supports, such as peer professional workers that are working directly with the clinical therapist, sometimes also with the primary therapist, sometimes also with the psychiatrist, that we've been very thankful in New York that we have been able to associate them and require some billing from. But that has been and continues to be always under fire. So I just want individuals to kind of be aware of those community-based supports that may not seem like it's a part of that integrative approach, but is very much needed to be.
Could not agree more, Angelia, and we stand ready to help you fight for those resources, community-based supports, and recovery supports, peer supports, family supports. The outcomes are so much better for people when
Yeah.
those exist. And we all know that. So it's the conventional wisdom of, kick your kid out, tough love. None of that works. We need to bring people together. And when people are supported, they thrive.
Yeah. And the point of entry is not always the primary care. I mean,
Yeah.
obviously we work with our individuals to ensure that they have a primary care provider. We know the importance of that. But we also have to be respectful of individuals and their autonomy and, how they generally tend to trend. And in some cases, not a lot of cases, the PCP is not the primary entry into healthcare. So,
It can be this community supports. Absolutely.
absolutely.
Excellent point. Okay, so it looks like we have a lot of work to do on this particular topic, but we have the right people here to fix the whole thing. Okay, so we're getting down to about another 10 minutes or so. So want to go back and talk a little bit about the pandemic. We've seen the sort of the very tragic numbers uptick here. New York immediately moved towards telehealth to try to maintain access for folks while they were quarantining. And, we've had a lot of conversations with providers and folks out there in the field, and all of the plans said it worked really well. They're really happy with it because it did maintain folks' ability to access their treatment. Wasn't a panacea, but I want to get your thoughts about how that worked and moving forward, and also starting with Courtney, really, how do we work telehealth as a treatment modality for substance use disorder into your measurement structure? So how do we do that? And are you must be thinking about that because you've been seeing it for the last several months. So I'll start with you.
Sure. Well, what we've seen is that telehealth really helps improve care, but it's not the end all and be all solution. We still need in-person services. We still, and a lot of clinicians and providers will tell you, I want to see this patient. I want to check in with them. I need to see how the medication's going. And that provides, a level of, in terms of the measurement-based care and quality, something you can't get over telehealth always. But telehealth is really important to help complement all of those in-person services and to make healthcare and addiction treatment more accessible to a larger amount of people. And to help scale is really important. Particularly, I think Senator Harkin mentioned it with clinic closures, and all of the provider shortages that we're seeing. We need to integrate telehealth, but I will emphasize that it's not the end all be all solution. We still need in-person when possible. And I would say we need a complementary approach. We also need to be mindful of those that do not have access to wireless internet, that would have to go to a library to access a computer, and might not have that ability in a pandemic. So those are just other considerations for us to take into account when looking at telehealth.
Right. Thank you. And we have talked about that with plans and providers in terms of equity, access to Wi-Fi and devices that you need, right? So that's definitely part of
Yeah.
this.
And would it make sense to, oh, I'm sorry.
No, go ahead.
Would it make sense to have prepaid cell phones for people so that they can access, that might seem like such a small thing, but could actually really help bridge the gap in terms of equity and access.
Right. Okay. Others like to add to that in terms of where we're going with telehealth? Senator.
Yeah, I would just chime in. One, I mentioned before the legislation we're working on for peers for Medicaid billing. But I would just want to go back a second, and Courtney is absolutely right on the digital divide. We see it in terms of education and how many of our students, because they don't have Wi-Fi, they don't own tablets or electronic devices, are being left behind. So it's not just a behavioral health issue, it's a societal issue that we need to address. The other thing I just wanted to touch on was how COVID impacted the industry. You know, while others were prioritized for PPE and the necessary things, the behavioral health community was largely left out of that prioritization. Excuse me, that's a mouthful. You know, OASIS wasn't even on the state emergency management team. So we passed legislation that the governor signed elevating OASIS to that team. But we need to remember when we have a crisis like this, and now it looks like we're going into a second wave, is when funding is being doled out, when PPE is being doled out, are our behavioral health providers getting the same benefit as other healthcare partners are? Because as mentioned, a lot of this needs to be done in person, whether it's inpatient, whether it's people receiving medication, that often has to be done in person. So we need to protect the folks who are the frontline workers, just the way we are in the rest of the healthcare community.
Thank you. Go ahead,
Kathy, I think, thank you. And I think telehealth has had a lot of benefits. If there's any silver lining in this, just being able to waive a lot of the regulatory pieces that probably years ago were pushed more for because of a billing or a fraud, concern. As one of my county commissioners said, see, you get rid of the regulations and voila, people get treatment. But in all seriousness, there's, it also, what we found is the no-show rate went down significantly, and no-show is a significant problem. Part of it was everyone was home, where to find someone, but even over time, the no-show rate decreased. Therapists were reporting that they could see the individual's home. Like, Courtney, I can see your nice, neat computer, and you can see that I moved all the stacks of stuff off my thing. You can see their whole environment, which is helpful, especially helpful in the kids system as well. But it also, if anyone who's ever tried to get Medicaid transportation, going to an appointment is a full-time job, right? So this kind of helped both solve that issue temporarily and also the workforce shortage too, to be able to bill in a more flexible way. But the concerns too with broadband, internet access, through the TANF program, you can get phones, but they ran out of minutes, we were finding. And also, again, we need HIPAA compliant platforms, which we don't have right now as well. So, and also, clinical judgment of the clinician. Senator, you mentioned it of why is 30 days the magic charm, and we would say, why is 45 minutes the magic charm? Let the clinician determine what the client needs, whether it's in-person, telehealth, 15 minutes, 20 minutes, because it also can help open up more access. We have workforce shortage in therapists. We have huge workforce shortage in psychiatrists and other, prescribers. So I think there's a lot of opportunity here. I'm hoping that at the end of the day, we'll see a nice streamlined authorization for telehealth with lots of flexibility and some assistance to get things going, to be HIPAA compliant and allow for broadband.
Great, thank you. Angelia.
Yeah, just exactly what my colleagues are saying. I mean, telehealth addiction is very much a relational disease, right? Recovery is very relational as well. So telehealth served its purpose in terms of being a bridge. A bridge is certainly not the only way to get there, which is why we are very proponents of multiple pathways. And so, but what telehealth did for us, we actually did a survey right at the beginning of COVID with regards to the peers in the workforce and asked them about telepractice and telehealth and all of these, and what did it look like? What did it feel like on the streets? And we had a split. About 49% was not in favor, and about 51% was in favor of it. But the most important thing is that in a time of crisis, folks recognized the need for our individuals to receive this critical care. And however we needed to do that, we did. And so telehealth became very, very important to us at that point. I mean, telehealth has been around. It has been underutilized, right? It never has really been scaled up to a level that we've seen it now and for obvious reasons. So multiple pathways. I mean, telehealth is certainly not the end all, but when it was time and we needed it, and it continues to be something that puts our individuals in front of individuals that need that care right then and there. So.
Okay, thank you.
Can I also just
Please.
add in terms of, because Angelia just made me think of this point in terms of multiple pathways, and from a policy perspective, there is a bill in the New York State Assembly and Senate right now around long-acting injectables and the ability for pharmacists to administer those for patients. And that's another pathway that helps reduce stigma and access. It's the law in 42 other states. So New York is a little bit behind on this one, which I don't like to say because they're usually at the forefront of everything and sort of setting the stage. But, you know, we should allow pharmacists to administer medications just like they would a flu shot for serious mental illness and substance use disorder. It would really help increase access and reduce stigma.
Okay, well, that's all the time we've got. Great discussion. Thank you, Courtney, Angelia, Senator, Kelly. Appreciate your time. Obviously, we still have a long way to go here, but we're going to work together. So thank you. Right now, we will be taking a 15-minute break and returning promptly at 11:30. In the meantime, please join Pondera Health Solutions for a virtual coffee break. Return to your agenda page and click on the link to join in a live discussion. And one more thing, remember, this is your opportunity to collect points as part of the gaming challenge. So please be sure to check out our sponsor and exhibitor section. And thanks again to all of you. This has been a great discussion.
Thank you
Thank you
very
for the
much.
opportunity.
Thank
Thank
Take
you.
care.
Take care. Bye-bye.